Good afternoon, everybody. I'm Jill Jacobs, and today we're going to be talking about CT evaluation of abdominal trauma. Accidental trauma is currently the leading cause of death in individuals less than 35 years old, and it's the fifth most common cause of death overall in the United States. And approximately 10% of those traumatic deaths are due to intra-abdominal injury. In the past, diagnostic peritoneal lavage was really the mainstay for diagnosis, and it does have many advantages, including the fact that it's fast, it's inexpensive, there's no need for contrast or radiation, and no need for patient transport. But the disadvantages of diagnostic peritoneal lavage include the fact that it's insensitive to retroperitoneal injury, it's not organ-specific, and you get no information on the severity of injury present. And this is another pitfall. This is a case where a diagnostic peritoneal lavage was performed, but the physician who performed it had no idea that the patient had an ectopic kidney down in the right lower quadrant, and I don't think you could do this twice if you tried, but managed to spear that kidney with the peritoneal lavage catheter. But I think that's okay because there are many advantages of CT evaluation of abdominal trauma. CT helps to improve diagnostic accuracy and clinical management planning, and contributes to decreasing negative laparotomy rates. In the past, as many as 25% of exploratory laparotomies due to positive diagnostic peritoneal lavage were negative in the operating room. The advantages of CT are that it gives you a global evaluation of the abdomen, retroperitoneum, and pelvis. It gives you organ-specific localization of injury, and it also gives you information on the severity of injury. The disadvantages we're well aware of. It requires IV contrast and radiation, it requires patient transport, and it also requires a clinically stable patient. But the power of CT is really evident in this paper that was published by Livingston in the Journal of Trauma in 1998. They did a prospective multi-institutional study of 4 level 1 trauma centers, and they evaluated 2,299 patients with physical examination, CT examination, and inpatient observation. And what they found was that CT's negative predictive value based on the subsequent need for ciliotomy was 99.6%. Interestingly, they also found that of the 61% of patients who had abdominal tenderness or bruising, only 22% had positive CTs, and conversely, 19% of patients with positive CTs had no abdominal tenderness at all. So the conclusion was that abdominal tenderness was not predictive of abdominal injury, and that patients with a negative CT after blunt trauma don't benefit from hospital admission or prolonged observation. The protocol that you use for trauma patients is going to vary depending on what scanner you use. In general, we scan by fives. We use an 80-second scan delay for most patients. We do give oral contrast material, and I'll discuss this a little bit more in just a second. And we do always want to try and give these patients intravenous contrast material. And we, in general, inject at a rate of about 2 cc's a second. Now, it is slightly controversial whether or not to administer oral contrast in trauma patients. Many surgeons don't want to administer it because they're concerned that these patients may aspirate. There's concerns that it can increase the delay time to diagnosis. And it's also questionable how much added diagnostic information you get. But there are many studies that have been published that show that you can administer oral contrast safely, including a study that was published by Federle in 1997, where he evaluated 510 patients and had no adverse reactions, and a study by Nastansky, who evaluated over 1,000 patients, and of the patient population, only one of these patients had aspirated the contrast material. So we do try and give gastrographin whenever our surgeons will allow it to be administered. I always want to get as much information as I can, and so occasionally you do get significant information by giving oral contrast, and that's shown in this patient. You can see there's an NG tube, and you can see that there's oral contrast extravasation due to disruption of the duodenum. Another really important clue to injury is the presence of hemorrhage. Hemoperitoneum classically has density measurements of greater than 25 Hounsfield units. Clotted blood is generally greater than 60 Hounsfield units, and we're always going to look for arterial extravasation. If it's focal, the density is usually between 80 and 130 Hounsfield units with surrounding hematoma, and if it's diffuse, it's generally between 120 and 170 Hounsfield units, and usually within about 15 Hounsfield units of the adjacent arteries. I show this slide to just remind you to always look at the most dependent portion in the pelvis, because that's usually where you'll see just very small amounts of hemoperitoneum. In this case, you can see a fluid hematocrit level down in the dependent portion of the pelvis. This is what a classic blood clot looks like. This patient had splenic injury. You can see this focal blood clot in the spleen with surrounding hematoma and contusion also in the spleen. This is a patient who had active bleeding into the liver due to liver laceration, and you can see the high-density focal region of bleeding surrounded by lower-density clot. And this is active arterial extravasation in this patient who has fractures in the right lobe of the liver. You can see the bright extravasated arterial flow, and you can see the surrounding hemoperitoneum. The importance of the sentinel clot has been described in previous papers published by Oregon federally. They looked at a retrospective study of 120 patients with visceral injury, and they found not only that the sentinel clot was present in 84%, but importantly, it was the only clue to the source of bleed in 14% of patients. So this can be a really important sign where the origin of the injury is. And in general, the density of the blood is going to be highest closest to the organ of injury. So this is a patient who had had a mesenteric injury. You can see that there's high density blood measuring 58 Hounsfield units near the anterior abdominal wall. And as you come down into the pelvis, you can see that there's also blood in the mesentery at this level, but it's decreasing in density, 44 Hounsfield units here, 30 Hounsfield units down in the right lower quadrant, and 27 Hounsfield units as we get down even more inferiorly into the pelvis. One thing I want to caution you about, however, is that you can have low-density hemoperitoneum. This is a study that was published by Levine in 1996, where there were 42 patients who had either hepatic or splenic laceration and free fluid, and they looked at 131 total fluid collections, and what they found was 24% of them had density measurements of less than 20 Hounsfield units. And when you looked at the mean fluid attenuation values in 42 patients, 10% were less than 20 Hounsfield units. So the conclusion is that fluid less than 20 Hounsfield units in trauma patients cannot simply be dismissed as ascites. You have to really be careful when you're seeing free fluid in trauma patients and make sure that you're excluding injury first. And this is an example of a case that I had. This is a patient who had multiple lacerations in the liver, and you can see this low-density fluid surrounding the liver. In fact, it measured about 19 Hounsfield units, and this was all hemoperitoneum related to these liver lacerations. This is another patient, multiple splenic lacerations, as you can see, and you can see low-density fluid surrounding the liver and spleen, and when you actually put density measurements on this fluid, you can see in both places it's less than 20 Hounsfield units, but again, this was all hemoperitoneum related to the splenic injury. So the question is, why does this happen? And it's presumed that what happens is that there's lysis of red blood cells, which causes a subclinical peritonitis that in turn induces peritoneal transudation, and bowel peristalsis incites rapid clot lysis. So again, be very, very careful when you see any kind of fluid in patients who have had prior trauma. So this is one of my favorite requisitions. This was from years ago. Wild sex, rule out splenic rupture injury. So I want to go organ by organ now and discuss injury. And the spleen is the most commonly injured organ. In case you're wondering, wild sex is not the #1 cause currently in the United States. I'm not sure if that's good or bad, but it is the #1 site of CT-diagnosed active bleeding, the spleen. And CT is very good at looking at splenic injury with sensitivities and specificities of greater than 95%. And this is the classic appearance that you're going to see for a splenic laceration, this linear low-density lesion traversing the spleen in this case, and you can see the surrounding hemoperitoneum. Another case, you can see this region of laceration and low-density hemoperitoneum. You can see a laceration traversing the spleen at this level and a large amount of hemoperitoneum. And again, I want you to notice that the density of the hemoperitoneum is higher, closer to the organ of injury than it is around the liver. This is a case of a shattered spleen. You can see little bits and fragments of what's left of the spleen, large amount of hemoperitoneum. And this is one of the pitfalls. This is a splenic cleft. Splenic clefts in general occur along the medial surface of the spleen rather than the lateral surface, whereas most lacerations occur along the lateral surface. And the margins of splenic clefts are generally very straight and much better defined than the margins of splenic lacerations. This is another pitfall. You can see that the spleen looks very heterogeneous in this case, and that's because this is an arterial phase image that I took from a patient who had a three-phase study of the liver. This is the portal phase, and you can see that the spleen is normal in appearance during this phase. So, of course, you never want to try and diagnose injury during the arterial phase. And, of course, the next question is, why would you ever scan during the arterial phase? And I know you wouldn't be crazy enough to try and do that when you have a trauma patient. But I show this because sometimes you have patients who have suffered trauma who come in and they have cardiac disease, and so you try and image during the portal phase, but because their cardiac output is decreased, you end up imaging a little bit too early during this phase of enhancement. And if that happens, just immediately go back and rescan the spleen so that you can scan during a more homogeneous portal venous phase. This is a patient who had multiple splenic lacerations, as you can see, with a large amount of hemoperitoneum. This was the initial scan in March, and then this is a follow-up scan 3 months later. And this patient, as you can see, had very good healing of this splenic injury, even though it looked horrible on the initial trauma scan. So this patient did not need to go to surgery. Which brings us to the point, how good is CT at predicting what patients need to go to surgery? And as you know, splenic salvage is really important because it helps to decrease the risk of infection. So you always try and salvage the spleen if you can. And it's been somewhat controversial whether or not classification systems are useful in the surgical literature. This is a multi-institutional study that was published in 2000, as you can see, and what it shows is that using the scale of injury, grading scale, the higher the grade of injury, the more common it was for patients to have to go to surgery. So ultimately, the decision whether or not these patients need to go to surgery is going to be based on their clinical status, with a few caveats. It's very important for us as radiologists to detect the presence of either splenic, pseudoaneurysm, or active bleeding. And there have been studies shown that if you have either one of those present, that most of those patients will end up needing to go to surgery. This is a study published by Gavant in 1997, and this study showed that the failure rate for non-surgical splenic injury can be markedly reduced if patients with traumatic artery pseudoaneurysm or active hemorrhage are treated with early surgical or endovascular repair. And this was also confirmed by a study that was performed in 1998 by Federley, who looked at 150 patients, and of 28 patients who had active hemorrhage, 93% needed surgical treatment. So again, if you see pseudoaneurysms or active hemorrhage, make sure that you tell the surgeons or the trauma team covering that patient, because most of those patients will need to go to surgery. This is a case that we had in 1998. This patient came in through the emergency room following blunt trauma, and this was unfortunately read as normal. The patient was discharged from the hospital, but in retrospect, what you can see is this focal region of increased attenuation here within the spleen, and this in fact was a pseudoaneurysm. This patient, came back 7 days later complaining of acute abdominal pain. And you can see now that this area ruptured. This patient has multiple lacerations, extensive hemoperitoneum. So that, in retrospect, should have been called a pseudoaneurysm. That patient should have been at least observed within the hospital and likely needed to go to surgery at that time. Moving on to the liver, it's the second most frequently injured organ. Right lobe injuries are most common, and CT classification systems are not really useful for predicting which patients are going to need surgery. This is the classic CT appearance of hepatic lacerations, these branching linear low-density areas, most commonly in the right lobe of the liver. This is another case. Again, you can see the multiple hepatic lacerations, and I show this case to always remind us to make sure we look at the vessels and see whether there's any vascular involvement when you have these lacerations. The surgeons like to know about that before they get into the operating room. And the other thing that you always want to look at is the diaphragm. You can see there's a large amount of blood here behind the right lobe of the liver, and this patient, in fact, did have diaphragmatic rupture. So always look at adjacent vessels and the diaphragm. This case I like because it shows the importance of intravenous contrast. This is a patient who had come in for a trauma scan. They attempted to give intravenous contrast, but unfortunately the stopcock was turned the wrong way, and the technologist didn't notice and scanned the patient first without giving contrast material. And it looks pretty normal. There's no blood around the liver. The liver parenchyma looks really pretty normal. But we went back and rescanned this patient with intravenous contrast material, and now you can see the multiple hepatic lacerations present within the right lobe. And this is just side by side to show you that they have multiple lacerations, and it's really virtually impossible to detect on the scan that was performed without contrast. And you can miss very significant injury if you don't give intravenous contrast material. This is a case that I had when I was at the University of Pennsylvania. This is a 17-year-old driver who had an auto accident. The EMTs found him unconscious at the scene of the accident, and he had his 3-point shoulder strap with the strap under his armpit. Came in, we scanned this patient, and what you can see is that he has several splenic lacerations, but in addition he has this area of active arterial bleeding, and when you look at the left lobe of the liver you can see this jagged edge, you can see the large amount of hemoperitoneum here. As we scanned more inferiorly, what you can see is this is actually the avulsed piece of his lateral left lobe all the way down into the pelvis, again with a large amount of hemoperitoneum. And what happens is when you wear your shoulder restraint properly and you have a deceleration injury, the forces are transmitted to your shoulder and rib cage. When you put the shoulder strap under your arm, those forces are then transmitted down lower into the region of the left lobe of your liver, and if you're a passenger, into the right lobe of your liver. So tell all of your family and friends, make sure they wear their seatbelt appropriately. This patient ended up going to the operating room, had the left lobe oversewn, had a splenectomy in the operating room. This was looked at but was not salvaged. They just left the left lobe down in his pelvis, and he was discharged and did well 6 days after he entered the hospital. Moving on to laceration healing, this is a patient who had a very large laceration in the dome of his liver, and 3 weeks later you can see that there's only minimal low density remaining at the site of the laceration. And the question is, how long does it take for these injuries to heal? Hemoperitoneum typically resolves within about a week. Intrahepatic lacerations usually about 3 weeks, and subcapsular hematomas can stick around for about 6 to 8 weeks. Intrahepatic hematomas and byelomas can actually remain for several years, but they tend to slowly contract and get smaller. Moving on to the pancreas. The pancreas is injured in about 3 to 12% of cases of abdominal trauma, and the pancreatic body is the most common site of laceration. With a deceleration injury, the body typically ends up smacking against the spinal column, and that's why it's the most common site of laceration. Mortality is extremely high, 16 to 20% for undiagnosed fractures, so you really want to have a very high index of suspicion when you're looking at the pancreas in patients who have had trauma. And this is a characteristic appearance. You can see this linear low-density laceration traversing the pancreatic body in this case, and this is one of the very, very important clues that you're going to look for. You can see this small amount of fluid here interposed between the splenic vein and the pancreatic body. And in a series of pancreatic trauma cases that was published, this finding was present in over 90% of cases. So when you see fluid interposed between the splenic vein and the pancreatic body, look very, very carefully for the presence of a pancreatic laceration. This is another case. This patient had multiple pancreatic lacerations in the body and tail, and again you can see this fluid interposed between the pancreatic body and the splenic vein. This patient also had an arterial injury, an injury to the aorta, and you can see this very high density arterial extravasation. This is coronal views of the same patient. Again, you can see the regions of laceration, diminished enhancement in the pancreatic body and tail, and the area of active extravasation from the aortic injury. Pancreatic head injuries are associated with duodenal injuries, so if you have a pancreatic head injury, look very carefully at the duodenum and vice versa. This is a patient who had an injury to the pancreatic head. Again, you can see this linear low-density hemoperitoneum and laceration, fluid again between the splenic vein and the pancreatic body. You can see this oblique laceration here through the pancreatic head, and you can see hemoperitoneum surrounding the pancreas. And in addition, you can see the circumferential thickening of the second portion of the duodenum due to intramural hematoma, so there was associated duodenal injury in this case. Gallbladder and biliary trauma is extremely important to pick up. About 80% of injury to the biliary tract is going to involve the gallbladder and about 20% to the bile ducts, but you can see that there's about a 20% mortality associated with undiagnosed bile duct laceration, so it's really important to diagnose it. This is a patient who came in complaining of right upper quadrant pain after blunt abdominal trauma. And when you look at the gallbladder, you can see this very high density material within the gallbladder lumen, which is all blood, and you can also see high density thickening of the gallbladder wall. This is another patient also complaining of right upper quadrant pain after blunt abdominal trauma. And when you look at this patient, you can see that there's marked thickening of the gallbladder wall, which is low density. This patient was taken to the operating room and was found to have a complete gallbladder avulsion. And this is an unfortunate woman who came in after a motor vehicle accident. She was having tremendous amounts of abdominal pain and was becoming a little bit hypotensive, but they really wanted her to be scanned. When we put her in the scanner, you can see that there are multiple hepatic lacerations. When we scan more inferiorly, you can see this abrupt cutoff of the hepatic artery due to a transection. You can see the large amount of hemoperitoneum in the right upper quadrant. As we scanned even more inferiorly, you can see this active extravasation from the portal vein with extravasation of contrast material here from both the artery and the vein. And when we scanned even more inferiorly, you can see that there was a linear laceration through the pancreatic head. And in addition, you can see that there was a portion of the wall of the common bile duct which was missing. So this patient had transection of the hepatic artery, of the main portal vein, and of the common bile duct, in addition to hepatic lacerations and pancreatic laceration. And unfortunately, she didn't survive this trauma. Moving on to the adrenal glands, they're injured in about 2% of cases of abdominal trauma. The right is more commonly injured than the left. The important thing with the adrenal glands is that 95% are associated with ipsilateral chest abdominal or retroperitoneal injuries. So when you see an adrenal gland injury, look very carefully for an additional associated injury. And complications include adrenal insufficiency if you have involvement of both adrenal glands, or if you have a very large adrenal gland hematoma, you can cause compression of the inferior vena cava. That causes, in turn, slow flow and can lead to the formation of inferior vena caval thrombus. So this is the most common appearance for adrenal injury. In this case, you can see this round, high-density hematoma within the right adrenal gland with a little bit of surrounding blood. This is another very common appearance where you have this ovoid, high-density hematoma here within the right adrenal gland. This patient also had multiple associated hepatic lacerations, as you can see, and hemoperitoneum. The other CT appearances that you can have are diffuse glandular enlargement, and you can actually just have obliteration of the gland because you have so much blood adjacent to the adrenal gland. Important ancillary clues to look for are the presence of ipsilateral thickening of the crus of the hemidiaphragm, as you can see here, or you can also have stranding of the periadrenal fat, as you can see in this case. This is a patient who came in who had this round hematoma within the right adrenal gland, associated hepatic laceration, and this patient came back about 5 months later, and you can see that both injuries had completely healed. The kidneys are injured in about 5% of cases of abdominal trauma. CT is usually the initial diagnostic study, and angiography is reserved for further evaluation of CT findings for treatment of CT-diagnosed injury, or if a patient has very strong initial clinical suspicion for renal vascular injury. There is an injury scale that you use. Grade 1 is microscopic or gross hematuria with normal imaging findings, or renal contusion or non-expanding subcapsular hematoma without laceration. Grade 2 injury is non-expanding perirenal hematoma confined to the retroperitoneum, superficial lacerations less than 1 centimeter in depth in the renal cortex. Grade 3 are cortical lacerations greater than 1 centimeter in depth without extension into the collecting system or urinary extravasation. Grade 4 are lacerations extending through the cortex, medulla, and collecting system, or injuries to the main renal artery or vein with contained hemorrhage, or thrombosis of a segmental renal artery without parenchymal laceration. And grade 5 injuries are shattered kidneys or renal hylar laceration associated with devascularization. And these are just some examples. This is a patient who had grade 1 injury. You can see this very subtle region of decreased density in the cortex here in the right kidney. This was actually a case that happened in the middle of the night in Philadelphia, and the resident brought the patient back, knew they wanted evaluation a little bit later when the kidney was excreting, but the patient didn't come back actually until about 2 hours and 45 minutes later. But what you can nicely see is in this region of contusion, you can see delayed enhancement in the cortex in this case. This is a grade 2 injury where you have perirenal hematoma. This is a grade 3 injury where you have this large laceration extending towards the collecting system but not involving the collecting system. Again, you have blood surrounding the kidney in this case. Grade 4 injury where you have disruption of the collecting system with extravasation of contrast material from the collecting system bilaterally. And grade 5 injury where you have this shattered right kidney. Whenever you see fluid adjacent to the kidney in a patient who has had prior trauma, it's really critical that you get delayed imaging during the excretory phase of enhancement. This is a patient who had what looked like loculated fluid adjacent to the right kidney. You can see that there's definitely laceration in the kidney, and when you do delayed imaging, you can see that there's actually disruption of the collecting system and contrast material filling this fluid behind the kidney. This is another case, patient who had a laceration of the right kidney. You can see blood surrounding the kidney, and when you get delayed imaging in this case, you can see that there's extravasated contrast material from the collecting system that extended into the perirenal space. We always want to look for renal vascular injury. Arterial occlusion occurs in about 1 to 3% of patients who have renal injury. And this is a case of a patient who came in complaining of right flank pain following trauma. You can see the globally decreased enhancement of the right kidney compared to the left. Large amount of hematoma here surrounding the kidney. On a little bit lower scan, you can see that there is normal enhancement of the right renal vein, which is emptying into the inferior vena cava, normal enhancement of the left renal vein. And that patient had had arterial avulsion. This is a second patient. You can see the segmentally decreased enhancement anteriorly here in the right kidney, and you can see that there's thrombosis of this small segment of the right renal artery in this case. And this is a 34-year-old who was in karate class, had a kick to his abdomen, came in complaining of abdominal pain. And what you can see is the enlargement and decreased enhancement of the left kidney, which is also showing delayed enhancement. And you can see the large amount of thrombus here filling the left renal vein. Moving on to bladder ruptures, there are two types, extraperitoneal and intraperitoneal, and it's very important to differentiate these because the treatment is different. The treatment for extraperitoneal injury is conservative therapy, whereas the treatment for intraperitoneal injury is surgically. And this is an example of intraperitoneal rupture, where you see this large amount of fluid here in the abdomen surrounding these small bowel loops. As we come down more inferiorly, you see the fluid tracks all the way down into the pelvis, and you can't see the bladder, and that was due to intraperitoneal rupture. This is a second patient, but this is the classic appearance of intraperitoneal rupture on cystogram, where you have rupture usually through the dome of the bladder, and then you have escape of the urine out the dome of the bladder into the abdomen. And so these patients generally have a very distended bladder at the time of the deceleration injury, and the pressure causes disruption through the dome. So make sure when you're going on those long car trips, you stop and take a bathroom break every now and then. This is another case, intraperitoneal rupture. In this case, we had contrast material placed into the bladder. You can see that there's actually blood clot down in the bladder, and you can see the extravasation of contrast material into the abdomen. And this is a case of extraperitoneal rupture. This is typically associated with pelvic fractures. In this case, you can see the extravasation of the contrast material from the bladder down deep into the pelvis and multiple bony fractures of the pelvis. This is that same case. Again, you can see extravasation down into the left side of the pelvis also. This is a corresponding cystogram where you can see the extravasation of contrast material into the left side of the pelvis. And this is another patient who came in with multiple pelvic fractures. Again, you can see the large amount of blood down into the pelvis. As we scan more inferiorly, what you can see is that the Foley catheter ended up into the left side of the pelvis. And so I like to show this case to caution you, if you are going to do a CT cystogram, make sure that the patient does not have a urethral injury. Make sure the urethra has been cleared before someone starts to stick a Foley catheter into these patients to check the bladder. Okay, and lastly, the topic I want to talk about is bowel and mesenteric injury. These injuries are notoriously difficult to diagnose. Clinically, it can be very difficult because signs are initially present in less than a third of patients, and serum amylase levels are also very unreliable. They can also be easily missed with rapid diagnostic peritoneal lavage because these patients can have minimal bleeding. It can take 4 to 6 hours to develop a leukocytosis in the peritoneal fluid, so if you do a rapid diagnostic peritoneal lavage, you can miss that. But it's very, very important to diagnose these injuries because delayed diagnosis of 8 hours or more is associated with increased morbidity and mortality. So you must have a very high index of suspicion when looking at these patients. In terms of location, small bowel injury is 5 times more common than colonic injury after blunt abdominal trauma, and the most frequently injured segments are the proximal jejunum near the ligament of Treitz and the distal ileum near the ileocecal valve. And that's because the bowel is fixed at these sites and therefore it becomes more susceptible to shearing forces. In terms of colonic injury, the left side of the colon is more commonly injured than the right in blunt abdominal trauma, and the right and transverse colon are more commonly injured in penetrating trauma. So what CT signs are we going to look for? Well, there are specific signs, and they include the presence of bowel discontinuity, oral contrast extravasation, pneumoperitoneum, and pneumatosis, but unfortunately they're only seen in the minority of cases. So the more sensitive but less specific CT findings to look for are the presence of mural thickening, abnormal mural enhancement, intra or retroperitoneal fluid or blood, and the presence of mesenteric infiltration. Bowel discontinuity, unfortunately, is rarely seen because it requires precise contrast timing, but in the appropriate setting of trauma, it's 100% specific for the diagnosis. And this is a case that Alec Megabo had loaned me. This is a patient who had blunt abdominal trauma, and you can see disruption here of the duodenal wall. You can see the nice enhancement of the duodenal wall in these regions, but then this large gap. This patient ended up going to the operating room, and again, you can see the segment of disrupted duodenum. Oral contrast extravasation, again, is 100% specific in the appropriate setting, but very insensitive, overall 12% sensitive for the diagnosis. It can possibly confuse with intravenous contrast extravasation from vascular or renal injury, but it's very helpful to give oral contrast because it does help you in some cases. And this is a patient who had oral contrast and rectal contrast, and we can see this large amount of extravasated contrast material surrounding the bowel. This patient actually had an injury to the colon, to the descending colon, and the extravasation was coming from that segment of bowel. And again, you see the large amount of extravasated oral contrast material. Pneumoperitoneum overall has a sensitivity of about 44 to 55%. Pneumoperitoneum plus streaky mesenteric density or mural thickening is very suggestive of the presence of bowel injury. And pneumoretroperitoneum in the setting of duodenal thickening suggests duodenal injury. The thing that you have to remember is that pneumoperitoneum, when it's isolated, does not necessarily mandate exploratory laparotomy. There are other causes of pneumoperitoneum, including pneumothorax, barotrauma, and mechanical ventilation, prior diagnostic peritoneal lavage. So you always want to know whether the patient has had prior intervention before they came to the CT suite. And also even bladder laceration in a patient who has Foley catheter can cause pneumoperitoneum. This is an example of a patient who has pneumoretroperitoneum. You can see the large amount of extraluminal air here surrounding the region of the right kidney. And you can also see that there's contrast extravasation from the second portion of the duodenum due to duodenal injury. You can also see hemoperitoneum here behind the kidney. This is another case, a patient who came in following blunt abdominal trauma. In this case, you can see the high-density circumferential thickening of the duodenum due to the presence of intramural hematoma, and you can see this focus here of extraluminal gas due to the duodenal disruption. And it always helps to look at these patients not only on your normal windows, but look at them on lung windows because it helps to pick up subtle pneumoperitoneum and subtle pneumatosis. This is a patient who is a roofer who fell off the roof, came in complaining of abdominal pain, and you can see the circumferential high-density thickening of these jejunal loops in the left upper quadrant due to the intramural hematoma. But in addition, when you look on lung windows, it's easier to see that this patient has a small amount of extraluminal air here due to disruption of the jejunum, excuse me. There's another patient who was complaining of abdominal pain. This patient had a car accident, came in, and this was actually initially misread as being normal. But in retrospect, I think you can see this very subtle pneumatosis here in the wall of the small bowel. This patient was discharged to home and came back 4 days later complaining of abdominal pain. And now you can see the large amount of extraluminal gas and fluid here within the abdomen. As we scan down into the pelvis, you can also see this very large collection of extraluminal gas and air due to this abscess from the small bowel perforation. So very, very important to look for small amounts of free air and pneumatosis. Mural thickening is seen in about 75% of cases of transmural bowel injury. So it's very sensitive, although not specific. What you're going to look for is circumferential, high-density bowel wall thickening. It's typically going to be either in the duodenum or in the jejunum in the left upper quadrant due to intramural hematoma. Mesenteric injuries, again, you need a very high index of suspicion to diagnose these injuries. Think of mesenteric injury anytime you see hemoperitoneum in the absence of a solid organ injury. You're going to look for the sentinel clot sign, and you're going to look for the presence of interloop fluid or blood. Again, make sure that these patients haven't had a prior diagnostic peritoneal lavage. So this is the characteristic sign you're going to look for in mesenteric injury. You're going to look for interloop fluid or blood. It typically is going to assume either a triangular or polygonal shape. You're going to also look for the presence of mesenteric intravenous contrast extravasation, which is going to be diagnostic for laceration. This is another characteristic appearance of mesenteric laceration with hematoma. You can see these triangular points. Anytime you see points in the fluid, think about mesenteric injury here. Again, it usually assumes this kind of triangular appearance. And this is another case of mesenteric injury. You can see the triangular shape of the fluid in between the bowel loops here, and in addition, you can see the high-density extravasation from the vasculature, diagnostic of mesenteric laceration. This patient actually came in hypotensive. Again, you can see the high-density collections of fluid within the mesentery. Look at the points here again, and the higher density focally within the center of it due to vascular disruption. So lastly, I'm going to talk about hypovolemic shock. It's very important for us to be able to diagnose this. Again, you never really want to put an unstable patient into the CT scanner, but patients can become unstable while they're being scanned, and you may be the first person to notice that they're becoming hypovolemic. So the findings that we're going to look for are the presence of a small aorta and or inferior vena cava, decreased spleen size and globally decreased splenic enhancement. You can see prolonged renal nephrograms, or you can actually have decreased renal enhancement. And you're also going to look for the presence of shock bowel manifested by bowel wall thickening and increased mural enhancement. So this is a patient who became hypotensive. This patient had actually been resuscitated a couple of times in the emergency room. You can see the globally decreased spleen size and the decreased enhancement of the spleen. Normally the spleen is going to enhance at least as much and slightly usually greater than the liver. You can also see the slit-like appearance of the inferior vena cava. You have to be careful looking at this because the inferior vena cava varies with respiration, so it can sometimes appear slit-like on one image just due to respiratory variation. But if you see it looking slit-like on 2 or 3 images, that's suggestive that this patient may be hypovolemic. This is another patient, again, globally decreased spleen size and decreased splenic enhancement. You can see this patient had a shattered right kidney, large amount of hemoperitoneum within the abdomen. Look at the small size of the abdominal aorta in this case. And this patient also had shock bowel. This is the classic CT appearance of shock bowel, where you see this very bright mucosal enhancement of the bowel wall, which is typically fluid-filled. For shock bowel on CT, you're going to see diffuse small bowel wall thickening, usually in the order of 7 to 15 millimeters, dilated fluid-filled loops, and increased mural enhancement, as you just saw. And the proposed mechanism is that you get mucosal hypoxia, which leads to the loss of integrity of the mucosa, and IV contrast then leaks into the interstitium, and that's why the mucosal enhancement looks so bright. This is another case, a patient who came in after a car accident, hypotensive. You can see the globally decreased spleen size, decreased splenic enhancement here. As we scan down more inferiorly, you can see this patient had the typical pancreatic body laceration. You can also see that clue to the laceration, the fluid interposed between the splenic vein and the pancreatic body, slit-like appearance of the inferior vena cava. As we scan more inferiorly, we could actually see the very bright mucosal enhancement of the bowel due to shock bowel. This patient was refluxing contrast back from the inferior vena cava into the right kidney because he was becoming hypotensive on the CT table, and unfortunately this patient didn't survive that trauma. So I hope I've shown you that when the ambulance does roll into your bay, you can be okay in taking that patient straight down to CT to look at him on the CT scanner. I thank you very much for your attention.